morning, friends, seniors, colleagues, and juniors. So today we are going to discuss one of the important topic in ENT practice, that is management of symptomatic vocal cord paralysis. So how do we manage a case of symptomatic vocal cord palsy? So it depends on the phonetic gap. If the phonetic gap is minimal, less than 3 millimeter, then usually we go for voice therapy in the form of half swallow boom. Half swallow boom is a maneuver related to esophagus and swallowing, which helps in voice therapy and finally leads to management of minimal phonetic gap vocal cord palsy. Then coming to the bigger phonetic gap, in which there is more than 3 mm of gap. So in that case, it is again subdivided into two. Recovery is possible or recovery is not possible. If somehow recovery is possible, the case is fresh and it is recent in onset and 1 year of time has not passed, then we go for injection laryngoplasty. So in injection laryngoplasty, what we do, we go through the transcervical route, pass the needle through the neck, either through the hyoid bone or through the thyroid bone or to the or through cricothyroid muscle, and inject some fillers inside the vocal cord to decrease the phonetic gap and compensate the paralysis part. If the phonetic gap is large, more than 3 mm, and somehow 1 year has passed and recovery is not possible now, then we could go for static procedures like medialization thyroplasty, arytenoid rotation, adduction arytenoidopexy. But the problem lies that in these procedures, uh, like medialization thyroplasty, arytenoid rotation, and adduction arytenoidopexy, bulk and bulk of the cord is just somehow uh, increased, but we can't increase the bulk of the muscle. We can't increase the tone of the muscle. We can't improve the movement of the muscle. So these static procedures have got many limitations. It can't improve tone, it can't improve movement, just it increases the uh, bulk inside the cord of the vocal cord, inside the vocal cord. So what are the side effects of these procedures? The problems lying with these procedures are basically injury to the cranial nerve, 10 vagus nerve. Vagus nerve injury may be there, then uh, injury to the recurrent laryngeal nerve may be there while doing surgery. Then in children, it's very difficult. Then it's not satisfactory for professional voice users also. So what is the remedy for these static procedures? So the remedy is reinnervation of the paralyzed adductor muscle. So this is the ideal treatment now. So what we do, that we go for a donor nerve like Ansa cervicalis, and finally we uh, we do a nerve reanastomosis to the adductor muscles. So the surgery is known as adductor muscle reinnervation, and it is of two types again. The first type is the non-selective reinnervation. In non-selective reinnervation, what we do, that we take the Ansa cervicalis muscle after dissecting in the neck and identifying the Ansa cervicalis over the carotid sheath, and finally anastomose it with the distal stump of the recurrent laryngeal nerve, which we could find inside the neck. And again, it is of two types, Either it may be done extralaryngeally or it may be done intralaryngeally. Now, this procedure, which we have done, that we have anastomosed the Ansa cervicalis to the distal part of the recurrent laryngeal nerve. It gives bulk to the muscle, it gives tone to the muscle, but movement is again not achieved. Movement of the muscle has not been achieved, means adductor muscle has not started working yet. So the next better surgery is the neurotization of the affected muscle. So in neurotization of the affected muscle, what we do? We do the highly selective reinnervation technique, in which we again identify the muscle, again identify the Ansa cervicalis nerve, and reinnervate to the transarytenoid, interarytenoid, and lateral cricoarytenoid muscle. So, what is the advantage of that? It is the advantage is that it gives bulk, tone, and movement. All the component of the vocal cord palsy have been improved in this procedure, in this surgery. So, it is the best. So, in symptomatic unilateral vocal cord palsy, when the phonetic gap is more than 3 mm uh, and the chances of improvement is not possible right now. 1 year has passed. Then ideally we should go for non-selective reinnervation or highly selective reinnervation unless it is contraindicated. So, what are the contraindication of these reinnervation techniques? The contraindications are the age of the patient. If the patient is having age more than 70 years of age, then having chronic diabetes, and if somehow patient had cancer in past and had undergone bilateral neck dissection, and if the patient had gone radiotherapy, in those cases we should not go for this non-selective or highly selective reinnervation. So so now coming to the static procedure again. So if non-selective reinnervation and highly selective reinnervation is the treatment of choice, then what is the role of a static procedure? The role of a static procedure is to salvage the reinnervation surgery, that if somehow uh, these uh, these are contraindicated, this reinnervation surgery is contraindicated, in those cases we should go for these static procedures like medialization, thyroplasty, and arytenoid rotation and arytenoid arytenoidopexy. So coming to the future possibilities of management of unilateral vocal cord palsy, in future highly selective reinnervation of all the intrinsic muscles of larynx could be tried, and and we could also identify the highly selective motor and sensory nerves inside the recurrent laryngeal nerve and go for selective reinnervation, which is a future possibility. Then neurotropic agents could be tried to attract the adductor and abductor fibers, and lastly, laryngeal pacemakers are also the possibility for adductors and abductors. So, thank you. This is Dr. Navles Bachchan, MD Anatomy and MSc ENT, and practicing in Patna. Thank you.